Thanks very much. Well, it's a real pleasure to be here today on our second lunchtime chat. Martin?
Siri.
Yeah, well, you're in the hot seat, mate, and I'm very excited about this chat because obviously it has a lot of bearing on the work we do. As an osteopath myself, I'm really interested in some of the stuff that happens today. So my name is David Bowen. I'm the therapist manager here at Arthritis Action. I'm also a registered osteopath, and I've been really looking forward to the content of this. Martin, would you like to, actually before I go any further, I'd just like to say that we tried to design the questions that we talk through today via the stuff that was sent through from the people watching, from the members and the therapists who, prior to this recording, have sent in. So if we don't actually answer all of the questions we sent through, we'll do our very best in the time we have to do that. But if we run out of time, then we're going to endeavour to email answers to those questions moving forward. And also this video will be on YouTube, hopefully in the next week or so for people to rewatch. Yeah. So having said all that then, Martin, this is great, this is very exciting. Why don't you tell the audience a little bit about yourself, about what you do for charity?
Okay. Well, first of all, thank you so much for inviting me. I mean, it is rather nerve-wracking, but I hope the audience will find this chat informative as well as interesting. Now, as the Services Development Manager for Arthritis Action, I am responsible for the development of the self-management resource. For those of you that haven't seen that, please go on to our website and check it out. And on top of that, you and I are co-producing this lunchtime chat, which is within the services development remit. Now, dietetically, I run clinics at both Eastbourne and London, and also I do offer telephone consultation for our members.
Great stuff. Well, I think it's pretty obvious when anyone who works in the charity sector in health that diet is hugely impactful. Certainly in clinic, I speak about it to my patients a lot, and your colleague now for a while. And so I'd like to get your thoughts about the effects of diet and nutrition on pain and arthritis.
Sure. How long have I got?
About 30 minutes.
Oh.
So good luck with that.
But, you know, we chat about it in the office all the time, and, you know, that I can talk about this topic until the cows come home. But all joking aside, the dietary factors could impact arthritis in two ways: the preventative side and also the intervention. Now, the latter do receive quite a lot of attention and also enthralled by people who are living with this condition. And mainly because there's so much interest going on. And I think really this chat, I really ought to be focusing onto the intervention side of things. Now, before I do so, I just want to set the scene a little bit. Arthritis literally means the inflammation of the joints. And often we see like books and newspaper articles, social media, or even the internet, Dr. Google, tend to lump this condition into one entity. Unfortunately, this is not medically correct. In fact, there are different types of arthritis, and it can be broadly separated into two main groups. One of them is called the conditions of musculoskeletal pain. This includes osteoarthritis, OA. And by the way, I will refer to osteoarthritis as OA or rheumatoid arthritis as RA, just to ease a little bit. And well, going back to the categories, and the other category is inflammatory arthritis, like your rheumatoid arthritis, RA, your psoriatic arthritis, your spondyloarthritis, etc. Now, this is a bugbear that I would like to share with you, and it appears away from the hospital or the primary care settings, and the lay media often use a one-size-fits-all approach in terms of the treatment side of this. So it's a bit like in the Lord of the Rings, one ring to rule them all. And to me, you know, are you telling me that you know, all types of arthritis can be resolved by food avoidance or even dietary supplements? You know, one of the other things is you know, it tends to be, you know, people with RA and OA, they all have food intolerances and allergies. Now, if I use OA as an example, it is a heterogeneous condition with many different phenotypes, and is now being, you know, slowly being, you know, proposed. And muscle weakness is one of them. And then, you know, according to their sort of thinking, are you saying that by simply avoiding certain foods, it will help with that? But to be fair, I do understand that there are a few overlapping treatments like exercises. But certainly, you know, your arthritis is rather unique to you, and you're learning about, you know, your conditions, understanding the therapies that are available to you will help with your self-management. Oh gosh, I understand now I'm steering way off about nutrition, so I do apologize. So bring me back.
Yeah, sure.
So whenever I talk about diet and arthritis, it's always been, you know, both fascinating as well as frustrating. The fascination really comes from, you know, learning, you know, about, you know, how much that we progress in understanding this condition or disease, and also some of the medical treatments that are used to help patients. In particular, you know, first off with RA, you know, you start with gold injection way back, and then the DMAPs, you know, now we've got the anti-TNF, the biologics, and then, you know, even now we've got the JAK inhibitors. Which are absolutely, you know, exciting. In contrast, myths about diet and arthritis, plenty of them out there, and also no solid diet therapy recommendations. Frustrates me.
I can imagine. Yeah.
Now, as we know, the main component of arthritis is pain. And according to a publication, 78% of people living with arthritis are in constant pain most days. And, you know, and coupled with certainly with a long-term usage of non-steroidal anti-inflammatory medications, which they have an undesirable health risk, that kind of makes, you know, dietary treatment somewhat attractive. Now, allow me to throw some figures at you. In terms of within the population of people with rheumatoid arthritis, 71% of them they believe that nutrition has got something to do with their arthritis. And half, or 50%, have done or have modified the diet, hoping that they could reduce the disease activities. So you may ask, is there any sort of validity in terms of whether diet works within this population? And before I answer this question, I just wanted to point out that the pain or flare-up from arthritis is intermittent. And sometimes, you know, during or approaching the end of flare-ups, people tend to, you know, elicit some form of treatment, rather a bit like, you know, changing the diet or cut out certain foods, and all of a sudden they become better. And then they kind of, you know, feel that, oh, this must be the treatment that helped me to get rid of some of my symptoms. And I think this is a little bit of a misconception. Now, that doesn't mean that you know, some modifying the diet wouldn't help with the condition. Take gout, for example. We know that cutting down on meat, animal meat, and also avoiding beer helps, but losing weight really is the key. Now, data also found that manipulating the diet may support a very small group of patients with rheumatoid arthritis or RA. But for those who think solely to use diet as a treatment, they are missing the forest for the trees. Because, you know, diet is just part of the puzzle. It's part of the jigsaw puzzle piece. And other lifestyle factors like, you know, keeping a healthy body weight, and also physical activities or exercises, and also smoking cessation can form a really powerful non-pharmacological management for arthritis. So the bottom line really is there's no specific dietary regime to manage arthritis. Some nutrients, which I'm going to talk a little bit more about later, may help, but we don't eat nutrients on its own. We eat a diet. And it's important for me to point out that we need to follow a dietary plan that is not going to cause any sort of nutritional deficiency. Healthy eating really is the foundation. And if you do think certain food that is causing symptoms, keeping a food and symptom diary and discuss it with your rheumatologist, GP, or dietitian would be really useful.
That sounds complicated, but also sounds logical as well. And I love the thing about keeping a diary. We do the same in clinic with pain and activity, as you know. I guess one of the things that springs to mind then, and one of the questions we've been asked, is foods like tomatoes. Where's the evidence with that?
Well, the famous nightshade vegetables.
Yeah.
These are, as you mentioned, the tomatoes and potatoes and peppers, like including the bell peppers, aubergines. And you know, if I could receive £1 British every single time I get asked this question, I probably will have enough money to buy a nice Ferrari.
You wouldn't fit in that. You're like a go-kart on you. You might be way too big.
But I would do that.
Well, I don't know, actually. You know how I feel about those sorts of cars. Anyway,
but anyway, it is not as simple as some people might have told you. So nightshade really get a really bad reputation, mainly because it belongs to this group called Solanaceae. Right. And Solanaceae family do have this alkaloid called solanine, and solanine has been purported to be extremely pro-inflammatory. Now, apart from sprouting potatoes, we haven't found any trace of evidence regarding this solanine in tomatoes. In a 1991 paper published in the journal Rheumatology, a few rheumatologists suggested rather than this solanine that is the culprit, is actually the vasoactive amine, which is the histamines that can be a problem in a few susceptible individuals. And I guess that this is why, when we look at the overarching data, that only so few people will react positively to food within the RA patient group. So it's certainly quite interesting. Now, I just want to put a spanner in the works for people who believe nightshades do have a role to play. A fair amount of papers have found that bell peppers are actually anti-inflammatory.
Right. Okay.
So, and also one of the medications, topical medications that we use for OA is actually made from chili peppers.
Right. Okay. That does throw a bit of a spanner in the works, doesn't it?
Indeed.
So what about dairy products, milk, for instance?
This is another food group that tend to get vilified by the media. I do understand that maybe cheese that are high in saturated fat, and we all do love our cheeses, and we do tend to eat more than that. On that sort of merit, we need to look out for. But ultimately, we'll be talking about things like milk. Interestingly, there's a 2014 study conducted over at a group from Boston. Don't know whether it's Boston University, but over in Massachusetts anyway. They examine a group of people and whether milk has got any association with their knee osteoarthritis. Yeah. And in that study, it has a span of 4 years to examine the actual effect. The interesting thing was, for those who are drinking 500 milliliters of milk per day or more than that, or twice daily, they found that they actually halt that progression of the knee osteoarthritis around about the 4 years mark. And that effect mainly observed in females rather than in men. And then in terms of what type of milk, the study did not specify. But one thing that they concluded that they need to do a little bit more work regarding that, because with any sort of nutrition or nutritional studies, there are a lot of confounding factors. So is it because they're drinking milk, they do exercise a little bit more? Because that may have quite a powerful effect, as you know.
Yeah, possibly. So what about if you're intolerant to milk?
We do then offer the milk alternatives, such as the soya, the almond, the hazelnut milk, as long as you'll just make sure that they are fortified with calcium.
I mean, from what you've said so far, it sounds like a real tightrope to walk in giving the right kind of balanced advice. That's a bit of a challenge, no?
Extremely difficult.
Yeah.
I mean, we are all individuals, and certainly we react to food, differently. And so, sometimes giving out a blanket statement is really, really hard. And really, my recommendation is got to be evidence-based as well.
Yeah.
So the key really is to listen to your patient to form a good working relationship. And this really formed the foundation of evidence-based practice. And if my patient wanted to modify their diet and they feel that by doing that, they're going to control the symptoms, I really have got no objection, providing the regime is not producing any sort of nutritional deficiencies.
Yeah.
And after all, patients are the expert of the bodies.
Absolutely. I'm a big fan of the patient being the expert. I think that's the way forward. So we've talked a fair bit so far then about foods there is no, or nutrients there is no evidence for. What do we know works?
Okay. Let me start this topic by looking at dietary fat. Now, we know that we all heard of omega-3 fatty acids. Certainly, omega fatty acids from oily fish, and in headlines, time and time again, has been being either cardioprotective or protect against joint pain. And we have actually got 10 years worth of data looking at omega-3 fatty acids and RA, and the outcome has been positive. But it is somewhat inconsistent with people with OA. Now, I have pinched this slide, and I do apologize, I don't know who I actually pinched it from, and this is actually came from last year's EULAR conference, and EULAR is a European League Against Rheumatism. And I am just a little bit disagreed with the fact that the speaker said that a high amount of omega-3s is going to be helpful for people with osteoarthritis, because at this present moment, the data doesn't point out to that direction. But no doubt, more and more evidence will slowly emerging, because I know that this is a really active piece of research. But when we look at this slide, in terms of looking at high-fat diet and physical inactivity, which is something that we're going to talk about a little bit later, and in terms of the high-fat diet, and something that we know from the literature is high saturated fat diet can be detrimental to the articular cartilage. Namely because from animal models, we know that they start then degrading some of the chondrocytes. And then the human study, similar effects has been seen. Now, if we look at the National Diet and Nutrition Survey, which is a surveillance system in UK, looking at the data, the most recent data, in terms of from the 19 to 64-year-old age group, their saturated fat intake. Now, before I go any further, I just want to explain, saturated fat is the fat comes from animals or certain plants like coconut. And the age group of 19 to 64, they score 12%, well, the intake on an average is 12%, and the recommended amount is just under 11%. and which, we are, slowly, understanding the message and being able to change, our dietary intake.
Sure.
But one group that I kind of wanted to pay a little bit more attention, really looking at it, certainly, from the musculoskeletal side, is the over 75 age group. Their saturated fat intake is around 14.5%, which is a lot higher. At this stage, we don't know the percentage of saturated fat that can be detrimental. A study pointed out to be 20%, which is rather high. That means that you need to, have takeaway almost every day in order to meet the amount. But, in particular in that age group, they tend to, they tend not to cook for themselves. They tend to, snack a lot.
Sure.
So where we find all the saturated fat, apart from, from meat and trimmings and so forth, are all the tasty ones like your biscuits, your cakes, and so forth. So so that would be something that just need to pay a little bit more attention to. But again, when we're looking at that figure, it's, from an average point of view, there may be outliers. So it is that outlier that I'm probably worried a little bit more about. Right. But moving on to olive oil. We know that from different data sets that olive oil have that sort of analgesic ability or effect. A Japanese group, I think 2 years ago, looking at the usage of olive oil in terms of the disease activity for people with RA, and they have found that if you are combining olive oil within the Mediterranean diet setting,
yes,
it does help to reduce disease activity for people with RA. Right? But saying that, who would drink olive oil on its own is usually, within the Mediterranean diet, which I'm going to talk a little bit about later.
Sure.
Now, the following is probably a little bit more interesting, because I certainly wasn't aware of this until recently. High-fat diet can actually shift the balance into more pro-inflammatory side of things. I mean, I probably wouldn't expect that, salt or sodium chloride will have that sort of ability to do so, but increasingly more and more data sets are pointing out that maybe you also ought to look at people's salt intake.
Okay.
Yeah, and then your vitamin and minerals, they are also quite popular, within the rheumatology patient group to have. So we're talking about the antioxidants such as the vitamin A, vitamin C, vitamin D, vitamin E, and also selenium. Now, if we take out vitamin D, just for now, looking at A, C, E, and selenium, on paper, it looks absolutely fantastic. But during field tests, we don't see any sort of benefit whatsoever. Right. And talking about vitamin D, we know that people with arthritis are usually deficient with this hormone or vitamin.
Sure.
And by supplementing with it, we would hope that it's going to have some sort of symptoms and numbing effects. But again, we haven't found anything. Apart from just correcting the existing vitamin D level, but we haven't really seen that sort of symptom modifying effect. Okay. So talking about a nutrient, sulforaphane, which is a sulfur-containing compound that's found in broccoli. Do you like broccoli?
I love broccoli.
Fantastic. And apparently, this sulfur-containing compound, it helps to protect against any further degradation on our articular cartilage. So it's extremely interesting, because I first noticed this way back, a few years back, maybe about 5 years back, and it's always been an interest of me trying to follow up to see what happened. And the group over at University of East Anglia, they've done sort of like a pilot or proof of principle study. So it's a small trial, only 40 patients, they're really looking at giving some of the pre-surgical patients 100 grams of broccoli per day, and then when they are actually being under the knife, and then the synovial fluid has been taken to see how much of that, how much of the sulfur-containing compounds in the fluid, and the result has been quite promising. So, it is something that I would hope that they're going to do more work on.
Okay.
Now, I have spoken extensively about some of the nutrients that have been shown or found to be beneficial. I mean, like many things in the biological system, they work kind of like in concert to one another. So I certainly believe that nutrients don't act on their own. There must be some kind of symbiotic behavior with all the nutrients. And then that kind of like leads us to, the overall picture, which is the diet pattern or the dietary intake. Sadly, not a lot of data regarding dietary pattern and arthritis, mainly because there may be a lot of confounding factors, and also people tend to drop out. I mean, if there's some sort of quite an extreme diet. So all in all, that side of things that we don't know too much. But one thing that we do know is that the vegetarian or vegan diet tend to be useful. And also, I just want to give a little bit more coverage for the Mediterranean diet or the Med diet. Now, back in 2009, there's a Cochrane review looking at different diet in terms of using that as a therapy for RA. And the conclusion was, in terms of the Mediterranean diet and the vegan or vegetarian diet, there's some moderate effect. And now, because of the methodology used or some of the trial design, they're not that perfect, so no firm conclusion was made. And similarly, the NICE guideline for people with RA, it did mention that if patients wanted to try the Med diet, by all means do so, mainly because Med diet is nutritionally complete. It's not one of those, wacky diet where, you cut out, certain, food group like your oranges and, all the citrus fruit and, hope for the best, so to speak. But there's also another usefulness, for people that think about using Med diet. Now, people with inflammatory arthritis, they are at a high risk of getting a cardiovascular disease. So we know that by adopting a Mediterranean diet, which has been found in quite a fair few evidence that it is cardioprotective, they can be extremely useful that way. And finally, we have conducted, we funded a study looking at using the Med diet and osteoarthritis. In particular, we are looking at some of the biomarkers for them and also your subjective indexes. And so far, it has been positive. But again, it is a small trial and it's also a pilot study. But there's certainly something for the wider research community to look at and really just looking at see whether any further association or further effect that we can conclude about adopting the Med diet for people with arthritis. And finally, one area I think that is going to be extremely important and is closely related to diet is our body weight. Now, if we are carrying more body weight than we should, and we know that that is something that is not ideal, and it is likely going to cause problems if we do have arthritis. Now, I always quote this, and it often makes quite a wow noise within the audience, is if you can lose 1 pound of the body weight, it will lessen 4 pounds of pressure on your knees every step you walk. And I think this study came out from Wake Forest University over in the States. And we also know that for people who are carrying more body fat or more body weight than they should, by combining diet and exercise together, they will see a much better reduction of pain and an improvement in physical function. And, and also, when we talking about how much body weight that we need to lose, it seems to be a dose-response relationship where the more body weight that you can lose, the better that there is a reduction of pain. So at the moment, evidence suggests that a minimum of 10% of body weight loss is ideal. But the studies conducted by Stephen Messier and also Professor Hunter, they have found that if you can lose your at least 20% of your body weight, it will further enhance that reduction of pain. And I think this is really important. And so far, I have only talked about OA, but in terms of for people with RA, carrying more body fat is not ideal either, because it will make some of your specialist medication less effective, which means that you will have a delay of remission. Sure. So in my clinic, I often refer diet and exercise as the golden twins. Sure. I wouldn't talk without chatting to my patients regarding the importance of them.
I agree. As you know, we'll talk a little bit more about that at the moment, hopefully we have time. That's fascinating. I mean, that was a long piece of information to get. So it emphasises how complex it is and what a balancing act your work is. You have to be very pragmatic. What I really picked up from that is about the sort, especially of people who are maybe at home more. I don't do as much shopping they do. They're probably doing more, ready meals, etc., with spice salt. The thing, as I was sitting here listening to you, I was thinking there's been a lot recently in the press about bacterial treatments, gut bacteria.
Friendly bacteria.
So what about that then?
All right, okay. Now, our gut has a maximum diversity and density of microorganisms.
Right.
And some with a rough estimate of around about 100 trillion bacteria. Now, these microbes, they tend to shape the development of the host immune system, as well as determining whether to switch the pro or anti-inflammatory responses on. Now, this field is ever evolving and also exciting area that we need to look more into. And they also found that there's a huge range of diseases outside of the gut that are associated with an abnormal or dysfunctional gut bacteria. Interestingly, a coexistence of gut and joint inflammation was found to be prominent in people with spondyloarthritis. Around 2/3 of the patients with SPA, short for spondyloarthritis, have microscopic signs of inflammation in their gut without any sort of clinical symptoms. And it has long been suggested for people with ankylosing spondylitis, following a low-starch diet has been helpful. Yeah. Now, a study published in 2017 by a group from University of Aberdeen has found there's no evidence of that, as well as excluding dairy intake or increasing fish oil consumption to dampen down the AS symptoms. In human study, all the human studies of RA, there is a strong association of gut microbiota in the pathophysiology and the progression of this disease. A display of gut dysbiosis has been observed. Now, I do understand that, there's a relationship between an imbalance of your friendly or commercial bacteria in our gut. Maybe using a probiotic supplement is going to help. Well, a few studies or papers have been made just to look at that, and at this stage, nothing conclusive has been found. Of interest, I just would like you to look at a study done by a researcher called Somani and his co-colleagues. And he used extensively the strain of Lactobacillus, Lactobacillus acidophilus and Lactobacillus casei and Bifidobacterium bifidum, to look at, see whether by ingesting this supplement, well, these sort of probiotic supplements, will have any effect on helping with the symptoms against a control group. As you can see there, certainly there's no difference between the intervention and the control group. Again, it can be due to the supplement they use or the methodology. So I guess that this is another area that we've really got to keep our eyes peeled on.
Absolutely. I mean, a bit controversial there. So, a lot of people, swear by probiotics.
Yeah, I do understand.
But the evidence is there to be seen. I mean, remaining on the theme then of being slightly controversial, there's a question that's come in which I wanted to ask from one of the members, which was the supplement glucosamine.
Oh, wow. Again, it is a really interesting topic. And we certainly receive pamphlets or flyers through our letterbox, or even as an insert in the Sunday papers, about certain supplements that take this and it will be cure of your arthritis forever. And you and I know that it is not going to be the case.
Yeah.
And sometimes when people are in constant pain, they will then start looking at any sort of ways to help them. And I think that specialist dietary supplements like glucosamine, often in people's first choices, because they are relatively inexpensive.
Yeah.
They are also really easy to get access to. Now, again, talking about the evidence-based approach in terms of answering this question, 2 studies has been set out to answer this, and these sort of studies are not just the randomized controlled trials. They are what we call systemic review, which means that they set a specific questions, and then they would look at all the available evidence from the research, from the field of research, and then they would then make a firm conclusion from that. Now, in terms of looking at the conclusion from taking dietary supplements, and all these dietary supplements has been studied, and we're talking about the glucosamine, we're talking about the turmeric, and the rosehip. All of them, seems to have a limited evidence to support their use.
Sure.
And what they mean by that is, from a short-term basis, which is less than 3 months, they all have been found to be effective. But you and I know, when people have got arthritis, it's not a short-term thing.
Yeah.
But when we start looking at data, extending to, let's say, 4 months or even beyond 6 months, either there are no data available or the supplements is actually not doing anything at all. Now, some of the supplements like glucosamine, yes, they are easily accessible, and certainly they are not going to be, harmful. But you need to take it for such a long time in order for you to see whether it actually has any effect. So we're talking about over 6 months to a year in order to see any sort of effect, if any. So overall, what I'm going to recommend is, if we want to try to use some of these specialist supplements, by all means do so, because overall they have been found to be safe. But if you are quite tight on your day-to-day budget, don't sacrifice your money on food or even your electricity just to buy some of these supplements.
Sure.
And also, really be careful of where you get it from as well, because with dietary supplements, they don't have a tight regulation.
Sure. What I would just like to say is that a lot of the information we talked about today can be also found on a fact sheet, which are online on our website, which really does lay out a lot of the stuff that Martin's already said. I'm very aware of the time, so the last few questions coming up, Martin. As you know, I've been developing strength and conditioning programs for people with hip, knee, and spine arthritis.
Really excited.
So I'm working with our partners in wellness. We've developed programs now to help people regain and maintain and develop their function, their independence via gaining muscle strength back around the joint. So what I'm really excited about is that some of the conversations we've had leading up to this, in that what can we do if someone's going to invest their time in doing those exercises to actually maximize those gains, just like you would with an athlete. What nutritional advice can you give someone who is slightly older with arthritis in what they should be eating to maximize strength gain?
Okay. You and I share the passion with strength and conditioning, and we often have numerous of conversations in the office. People with arthritis may also have sarcopenia.
Right.
Irvin Rosenberg first coined this term back in 1989, and it is defined as the loss of skeletal muscle, or skeletal muscle mass, and strength as a result of aging. Recent update of the definition is that there is a component of skeletal muscle loss, a loss of function, and other factors like chronic inflammation. Sarcopenia is accelerated by physical inactivity. And when someone lost muscle mass, they are likely to lose muscular strength as well. And in terms of OA, we ought to look at it as a condition extended beyond the articular cartilage, because there is evidence looking at some muscle loss, but it's mainly predominantly that there is muscle or skeletal muscle, tendon, and ligament weakness. And in order to increase muscular strength, we need to make skeletal muscle grow, just like a plant. And in order to increase skeletal muscle strength, apart from making it grow, in terms of the merit of muscular strength, and we have also been found that increasing that will help to reduce pain. And again, going back to what we have spoken before, that is probably one element that people want to find a solution to. Now, one way that is really going to be helping to increase muscle growth is to ingest dietary protein, because it is a rather important macronutrient. Anabolic resistance is found in older people with sarcopenia. And to combat this is to increase dietary protein intake. The current recommendation, for protein intake is around 0.8 grams per kilo per day, which is too low. And how can you build a house with a small amount of bricks, which is not going to happen? So more recent data suggested maybe we need to increase it to around or more than 1.2 gram of protein per kilo of body weight per day, or separating into 0.3 grams per protein per meal 4 times a day. Some people may say that, the high protein intake is going to be detrimental to your kidneys. And this is not evidence-based, but caution needs to be taken for people who have existing chronic kidney disease. So when is the best time to ingest protein? Like I said, in a separated dose 4 times a day, and on top of that, after you have done any sort of resistant training, that will be the best time for people to have dietary protein. And I would say that protein timing for priming.
Amazing. I love that picture, by the way. That's a strong look. I don't think I'll pull that tracksuit off.
You will look good in that tracksuit.
That's a very strong look, yeah. I don't know if I've got the bottle for that. But what I was going to ask you was, from a purely selfish perspective, as an osteopath, I know we've got osteopaths, physiotherapists, and potentially some other allied health professionals watching, because we're aware of the time kind of running away with us. What would you say would be the top tips for someone who works as an allied health professional if they want to give some advice to some of their patients and clients?
certainly within the MSK setting, nutrition should be all AHP's business, not only dietitians. The prime time really for you to initiate that sort of conversation is when you are assessing your patients. When you're just asking them about, are you eating enough? Are you having a regular protein intake? And we know from quite a few literatures that breakfast is really a problematic meal for people that try to increase or bump up their protein intake. So maybe if you know that somebody or your patient is not eating enough protein, suggesting that eggs are extremely useful as a little nutrient powerhouse, or even recommending sardines on toast, that can also be really, really good. And on top of that, if you come across some really difficult cases, refer to your friendly dietitian. Always happy to help.
Absolutely, absolutely. Well, I'm really aware of the time. Martin, that's been amazing. Really
Thank you very much for having me.
It leaves me just to say that any answers that we've been saying to, we will do our very best to answer those on email in the coming week, hopefully. Just to let everyone know that the next lunchtime chat will be with Dr. Wendy Holden, who's a NHS consultant rheumatologist, and she'll be talking about all things to do related to arthritis. So we're looking forward to that one too. That just leaves me to thank you, mate.
Thank you, sir.
Thank you for allowing us to take a swim through Lake Martin. And I certainly think that, certainly from my perspective, as a clinician, hopefully also to the members, that's been really, really informative. So thank you very much.
Thank you.